I'm Kazi. I'm the Associate Director of the Smith Center for Outcomes Research in Cardiology here at Beth Israel Deaconess, and I'm going to talk about the economics of the COVID-19 vaccine. This is what the next 12 minutes or so is going to look like. I'm going to start with making a case why we should really care about the cost of the vaccination. I'm going to split the cost into two buckets, the cost of the drug itself and the cost of getting that drug into people's arms, what I call the cost of the vaccine and the cost of vaccination, respectively. And I'll close with special economic considerations, including issues related to health disparities that we just heard about. Now, in preparation for this talk, I interviewed over a dozen health system leaders and supply chain experts. I did some field visits, I took copious notes, and I decided that at one point I needed to make for myself a simple schematic of what it would look like, what the supply chain looks like in a state which just has 3 hospitals, 2 pharmacies, and 1 nursing home. And this is what I came up with. And as I was standing there staring at this monstrosity of movement of vaccine and supplies and documentation and money, I realized that scaling this up to 50 states with thousands of hospitals and tens of thousands of nursing homes and pharmacies is going to make this the most complex logistical operation the United States has ever undertaken in peacetime. As part of my interviews, 2 themes started to emerge. The health systems leaders I interviewed almost consistently said something like this: "This is complicated. I have no idea how much it costs, but that's okay because it's important work." And the supply chain experts were using war metaphors. We need an army of vaccinators, boots on the ground, and we need to protect our supply lanes. Now, I'm no military expert, but I know one thing, that if you want to win a war, you've got to know your resources and deploy them strategically. And that brings me back to the question about why we should really care about the cost of the vaccination. It's not so that we can decide whether vaccination is cost effective or not. You don't need a health economist to tell you that a vaccine that's going to bring back our economy, our jobs, and the joy in our lives is actually cost effective from a societal perspective. It is. You can take that from me. But there are 3 reasons to carefully examine the cost of the vaccine, and they relate to some of the talks we've already heard. The first is knowing the cost is critical to scaling up and doing it fast, like Josh pointed out earlier. The second, and I'll make this case in more detail later in the talk, which is that knowing costs allows us to make the strategic investments we need to address health inequities. And finally, whether we like it or not, COVID-19 vaccination may end up being an annual exercise, and so we might as well learn a ton about logistics and costs this first time around. So how much does the vaccine actually cost? If we look at the budget of Operation Warp Speed, which was set up to facilitate rapid vaccine development, it was about $7 to $18 billion that they spent in the year 2020. About half of that went to Moderna and Pfizer, which, by the way, is more than the annual budget of the CDC in an average year. But there were other expenses, like to glass manufacturers, for instance, to ensure that there were vials. But if you take $17 billion and divide it by 200 million Americans, that's about 80% of Americans over the age of 16, then you end up at a cost of about 80 per person, 83 per person. But you could rightly point out that this is a combination of fixed costs, one-time costs, like the 800 million we paid Moderna to run the trials, and variable costs. And what we really just care is how much does a vial cost on the market as we go forward. Now, if you've done any pharmacoeconomics research, you know that the price of drugs in the US market is almost impossible to ascertain because it's shrouded in all these confidentiality agreements between vaccine manufacturers or drug manufacturers and purchasers. That's true worldwide, and it's also true for vaccines. But in a moment of exuberance, Belgium's budget state secretary tweeted out the cost of vaccines in Europe. Of course, she promptly deleted the tweet, but not before the internet had captured the data. So here are the costs of vaccines in Europe. We'll look at Pfizer and Moderna first. Best knowledge is that the Pfizer vaccine is about 30% more expensive in the US, so about $20 per shot. And Moderna is about the same price if you ignore the money we paid up front for the trial. It's about $18 per shot. We need 2 shots for the course, and so we could assume about $40 per person. And if you look at Oxford and J&J, the prices are slightly lower, but for now we're looking at paying $40 per American that is vaccinated. But that's for the drug itself. We now have to talk about other costs related to getting these drugs into people's arms. They include transportation costs. So the federal government has spent about $750 million on this contract for transportation. My hunch is that by the time this is done, this cost will double based on the complexity of the supply chain and the duration of this exercise. So that comes to about $8 to $10 per person vaccinated. Again, the metric I'm using is cost per person. And now the vaccine's been purchased, brought to the clinic. How much is it going to cost to actually run a clinic? There are two ways to do health systems costing. There's the traditional accounting approach where you say, my clinic has 10 full-time equivalents and they cost X, they vaccinate Y people, so it's Z dollars per person. That's the traditional approach. But about 2 decades ago, Bob Kaplan and others at Harvard Business School described this pretty elegant method of healthcare costing called time-driven activities-based costing, or TDB-ABC. I'll tell you that I used both approaches on one of our sites and got nearly identical numbers. So for today, I'm only going to present the TD-ABC results. How does that work? The idea is that you take the average patient and walk them through the series of activities that are needed to completely deliver a service. So in the case of vaccination, patient must be scheduled, checked in, someone prepares the vaccine, administers the vaccine, the patient's observed, they check out, and there's documentation that goes to the federal government. You then estimate how much each of these activities takes on average and what the cost is per minute of that activity, depending on who's delivering that service. And so I did that exercise, and here are some quick data. I talked to stakeholders and figured out the minutes per activity. I used national labor rates, and so Boston rates are likely higher, and got an estimate of $17 per shot. But that's assuming that our vaccinator is giving a shot every 5 minutes for 7 hours straight, which doesn't actually happen in real life, so you've got to budget some redundancy. You've got to budget overhead costs. There are 2 doses per vaccine and then some local supplies. And that gets us to $47 per person for getting that vaccine in someone's arm, which it turns out is remarkably similar to how much Medicare is paying for getting these vaccines into people's arms. But you can step back and say, well, Kazi, these are marginal costs of a vaccine in a pre-existing clinic. What do I mean by that? It means it's assuming that it's like any other vaccine and you're giving it in a clinic that already exists, neither of which is correct. As you know, that this is from our distribution site in Westwood, there are specific freezers. That's the -70 freezer for Pfizer. There's a cold room for Moderna. Both the vaccines and the supplies arrive in these big boxes that need to be broken down to make sure that the right number of doses and supplies get to the clinic on the day and are retrieved at the end of the day in some cases. And there's a small army of people doing this job for each of the hospital systems that's working on this. All of these are additional costs. And we also know now that we're not delivering these vaccines in our own clinics. We've actually rented, the BILH has 13, now 15 facilities going up, and other systems are doing the same in the community. So there's rent, facilities costs, transportation expenses, what I call second order personnel, which is a modeling term, meaning they're not directly involved in the vaccine delivery, but the folks who are involved in planning. It's almost a full-time job for many of our vice presidents. The IT support required for this process, patient outreach. My hunch is that all of this adds no less than $10, but up to $30 per patient. But even at the lower end of that scale, you can see here that a vaccine course that started out at $40 per person ends up being close to $110 and probably higher by the time you're done. When you scale that up at a state level, these numbers get pretty astronomical. And that's, you look at, you're talking about, even just for the state of Massachusetts, if we wanted to vaccinate everybody in 150 days, so that's 5 months, you'd have 1,000 vaccinators, 1,000 farm techs, and more vaccinating every day, 7 days a week to get this done. That's assuming perfect efficiency. And you're likely to see the costs get pretty high pretty quickly. So in hindsight, the previous administration's assumption that they could provide the vaccine and the states would manage all of the distribution without support seems pretty farcical. So let's talk about special economic considerations. Of course, I was talking about vaccines being delivered in clinics that deliver maybe 500 to 1,000 shots a day. If you could scale this up into mega sites that are, 2,000, 5,000 doses a day, there are some cost efficiencies in terms of how you manage your personnel, your vaccine doses, scheduling costs get down, and then of course rent per person might come down further. So you could say, well, we could do this for less than the amount that was estimated earlier. But at the same time, there's the opportunity cost. If we redeploy people who had other daytime jobs to delivering vaccines, what are they doing that they were not doing now that they were doing before? So if someone from the cardiology clinic is redeployed, what about their daytime job? Or if all the administrators are thinking about vaccine logistics, what are they not thinking about for the health system as a whole? So those are the opportunity costs that I haven't accounted for. And of course, the costs will change over time. So we might be able to negotiate better prices for the vaccines, unlikely, but single-dose vaccines are substantially going to reduce the cost both of the vaccine itself and the administration logistics. And there is the issue of what business folks called cost of customer acquisition. So we're starting out with 75-year-olds who might be less tech savvy and might require phone calls in multiple languages. Then we'll end up with this phase where, people will sign up online, and so the cost of signing up will be zero. And then towards the tail end, as you're dealing with more people who are on the fence about getting the vaccine, the cost of getting people vaccinated will go up again. But to touch on the point that Basila raised earlier, and which I think is really important, is you frequently see pushback like, yeah, okay, efficiency and dollars per quality adjusted life are great, but what about equity? We should be willing to invest in equity. And I will argue that this is a false dichotomy, that if we look carefully, these are very closely aligned. So let's take an example of a hospital system that wants to put in a small clinic in a community, say in a church in an underserved community. And you're right, based on what I just told you about economies of scale, that the cost per vaccine is higher in that smaller site compared with a mega site. But because this community is at greater risk of COVID and hospitalizations and death, the return on investment on that vaccine is substantially higher than you might get at one of your mega sites. And so the idea being that if you take a more comprehensive look at the economics of vaccine delivery, it in fact would support your case to make investments in underserved high-risk communities, including strategic location of sites, strong community partnerships, and the information campaigns that Basila pointed out just in the prior talk. And so while we won't solve this issue of well-earned issue of centuries of mistrust in the health system and underinvestment in our communities over one pandemic, but at this point there is both an economic and moral imperative to make these investments that might have long-term payoffs. So I'll close with these thoughts, that regardless of how you do the math, the last mile, which is again probably the most complex part of the logistics, may more than double the cost of the vaccine. There are enormous economies of scale to be had, but if we value equity, we should be willing to spend the money to achieve it. And with that, I'll pass it on to Iris.